All right, guys. Well, I'm Alexa Pagano, and today Dr. Sandritter and I are going to be giving a little talk on clinical benefits of CYP inhibitors. We do not have any disclosures. Like I was mentioned, we are coming to you from the Goldilocks Clinic. So it's kind of this cute acronym for that much longer name on the screen that I won't say all of it. But we are a clinic that sees a lot of kiddos for a variety of different medication questions. We do a lot of pharmacogenetic testing. So this is a topic that's very near and dear to our hearts. Objectives today, we hope that you'll be able to understand the FDA definitions for strong, moderate, and weak inhibitors, describe the mechanisms of CYP enzyme inhibition, name some of the medicines that are strong and moderate inhibitors of CYP2D6 and CYP3A4 and 5, and describe some clinical applications of CYP inhibition. So these cytochrome P450 enzymes, or CYPs, they are the most well-known drug metabolizing enzymes. They're predominantly expressed in the liver, but certainly we can see them in other tissues as well, like the kidney and GI tract and the skin. And CYP-mediated drug metabolism converts lipophilic products into hydrophilic products so that they are easier for us to excrete and get out of our system. They play a really important role in determining treatment outcomes by influencing things like drug action, safety, bioavailability, and drug resistance and treatment failure. There are 57 different CYP isoforms, but of all of those, really only about 10 individual CYP isoforms carry out the vast majority of CYP-mediated metabolism. CYP3A4 is the highest abundance isoform. It's going to metabolize the greatest number of drugs. On the flip side, CYP3A5 is pretty minimally expressed in most of the population, but in a minority of the Caucasian population, you will find relatively high amounts of CYP3A5 expression. And then CYP2D6, even though it's present in much lower abundance, I kind of think of it as an overachiever, and it metabolizes nonetheless still lots and lots of medications. So together, CYP, 2B6, 2C9, 2C19, 2D6, and 3A4 are responsible for more than 90% of known oxidative drug metabolism. So you can imagine then that with these CYPs being so important for drug metabolism, inhibition or induction of these enzymes can be a pretty significant source for drug-drug interactions. In general, CYP inhibition is much more common than CYP induction. Probably not surprisingly, CYP3A4 substrates form the majority of the drugs that are known to cause these CYPs-associated interactions. So under normal circumstances, you'll have a substrate that would be either completely or to a significant degree metabolized by one of these CYP enzymes. But then if you add an inhibitor to the equation, you would decrease metabolism of that substrate. And as a result, you can get an increase in the exposure to that substrate. These interactions due to shared CYP-mediated pathways are fairly frequent, and they can occur especially through reversible or irreversible inhibition, which we'll talk a little bit more about in a moment. But the magnitude of these interactions and kind of the downstream effects of it can vary depending on a couple of different factors, such as different affinity between the substrates for that enzyme, differences in concentrations of the competing substrates. Is there a time delay between the administration of these two different drugs, and what the mechanism of inhibition is? This chart is just to show you how the FDA categorizes these inhibitors into strong, moderate, or weak classes. And really, this is just to point out that they are defining it based on the magnitude of the increase in the AUC. This table gives some examples of CYP3A4 and CYP2D6 strong, moderate, and weak inhibitors. You can see for 3A4 strong inhibitors, a lot of these are going to be antifungals. There are some HIV medications in there. And then for CYP2D6 strong inhibitors, I'll point out fluoxetine. That's one that we see pretty commonly prescribed in pediatrics. Quinidine's another one, though certainly not seen as commonly. And then a few of these will have asterisks by them. And that's just to point out that this isn't entirely set in stone. And so some of this can change depending on the substrate. So for example, diltiazem on here is listed as a CYP3A4 moderate inhibitor. But if the substrate that we're looking at is buspirone, in that case, you can see an increase in the AUC of more than fivefold, which would kind of push that up to a strong inhibitor. So just to point out that there's some flex here with this, and it's not always a set in stone.
Okay, so when we're talking about our clinically significant inhibitors, it's important to notice that these drugs, the drugs metabolized here are mainly via one single pathway. So if a medication is predominantly metabolized by one specific enzyme, then you're more likely to see significant interactions with a drug that would alter the function of that particular enzyme. And this inhibition may lead to an increase in the steady state concentration and accumulation ratio of that particular substrate to the point that you could see nonlinear kinetics or more of a saturation of the enzymatic process that's metabolizing that drug. In charts of inhibitors, the listed substances generally are mostly strong or at least moderate inhibitors for that CYP enzyme. And this is really implies that the relatively strong affinity that you see to an enzyme is achievable at concentrations of that particular drug that we would use in the clinical management of disease. Variables that you might see would include the IC50 or Ki, and sometimes these are included in tables. We'll show you a couple of those. The Ki is a variable that tells you how strongly a medication binds to that enzyme, the concentration at which 50% of those sites for drug metabolism would be blocked by that particular substance. And most commonly, we're going to see competitive or mechanism-based inhibition when we're talking about clinically significant inhibitors. Ritonavir, I included in here just from a historical perspective when I was thinking about this topic of drug inhibition. Ritonavir was probably the first medication that I can really remember that was approved like for its ability to inhibit enzymes. So it was initially approved for HIV treatment at a dose of 600 milligrams twice a day, but that medication or at that dosage, the medication was not very well tolerated by patients taking it. However, at much lower doses of just 100 milligrams per day, you can see inhibition of 3A4, which then would boost the serum concentrations of other simultaneously used protease inhibitors that were much better tolerated to manage the HIV. Ritonavir has also been used to boost medications used to treat COVID-19 more recently. And then I just wanted to point out here that maximal inhibition of this enzyme, especially if you're using or thinking about the substrate midazolam, at least it occurs at about 48 hours of dosing of ritonavir. And then since ritonavir is a irreversible inhibitor or a permanent inhibitor of 3A4, you need de novo synthesis of that enzyme to begin metabolizing drug again. So this particular study that you see the graph here below was trying to show how soon after stopping ritonavir you would be able to metabolize medication again through 3A4, which typically occurred around day 3 to 5, where you were close again to about 100% disappearance of that inhibition. So the two types of inhibition that we really see are reversible and irreversible. Irreversible, sometimes you'll see referred to as mechanism-based. Reversible is the most common type and is generally due to weak bonds that are easily broken down from the drug or the inhibitor binding to that enzyme. So this inhibition acts really rapidly and does not permanently destroy the enzyme. This reversible inhibition is divided into multiple categories. Competitive and non-competitive are the most common, and we're going to go into those in the next slide. For irreversible, you can see that it's really much longer lasting, or is sometimes also referred to as suicide inhibition, because to reverse this type of drug-drug interaction, you need to resynthesize new enzyme that is not bound up by that drug substance. When you are looking at drug enzymes, so I have an image here, there is typically an active site where the drug is being metabolized, but also an allosteric site or another site where an inhibitor could bind to that enzyme to alter the function of the enzyme. So with drug-drug interactions through inducers or inhibitors, they can bind to either one of these sites to cause that impact. Inhibitors can also be substrates for this enzyme themselves, but they don't have to be. And drug binding to the allosteric site over here would result in a conformational change or a shape change to this enzyme overall that drug no longer can fit into the active site. For competitive inhibition, neither drug is binding onto the allosteric site. Both drugs here in orange and yellow are competing for the same site. The drug with the higher binding affinity will initially win out until you have a much greater increased concentration of your yellow drug or your other drug substance, to the point that the higher concentration can overcome that lower affinity, and then reverse this type of inhibition. With non-competitive inhibition, you see your inhibitor binding into the allosteric site of this molecule, altering the shape of your drug metabolizing site such that the medication cannot be metabolized. And once the inhibitor is removed or comes off of this allosteric site, the site here returns back to normal shape and drug metabolism can occur again. In or in your irreversible metabolism, your drug that binds into the active site here leads to a permanent covalent bonding within this site that alters the shape of this enzyme and the function of the enzyme permanently. So this molecule then no longer will come out of the enzyme and permanently destroys the function of the enzyme. So for this type of inhibition, you need resynthesis of the enzyme. And you'll notice that the allosteric site is not involved in this type of inhibition. For 2D6, we know that this enzyme is highly polymorphic and there are greater than 100 alleles that have been identified. The polymorphisms can cause a wide range in clinical variability of this enzyme, from poor metabolizers all the way up to ultra-rapid metabolizers. And I've included the activity score way to categorize these different metabolizer sites. 2D6 metabolizing enzyme metabolizes active drugs, into inactive metabolites, but 2D6 is also known to turn inactive drugs into an active substance, such as one that we're probably all well familiar with, codeine. So in that regard, 2D6 activity or inhibition can result in adverse drug reactions or decreased drug effectiveness. Here again are some of the medications that are considered strong inhibitors. Fluoxetine commonly being used in the pediatric population with some of the KIs that you will see. And I thought this was really interesting in at least one study that looked at the 50 most commonly prescribed drugs in the United States. There are several substances in there that come up that are significant inhibitors for 2D6. So it's always important to look for these drug-drug interactions in patients, especially those that might be on your anti-anxiety medications or antidepressants. Nudexa is a new drug product that I was very unfamiliar with, but when looking it up, found out that this is a drug combination that utilizes dextromethorphan plus quinidine. The quinidine in this drug combination is being used as a CYP2D6 inhibitor. So it doesn't have functionality other than the inhibition of 2D6, which enables increased concentrations of dextromethorphan that have been shown to be effective in treating pseudobulbar affect disorder. And this is a disorder where you see frequent crying or laughing episodes that are out of context to the situation in which the patient may find themselves in. Newer to the package insert, on a more recent look at that product's package insert, they do now include information about poor metabolizers, saying that you might consider genotyping someone before starting this medication, because the quinidine will provide no additional benefit if the patient is already a poor metabolizer. Dextromethorphan is rapidly metabolized after oral dosing, which really limits its systemic exposure. So if you're using dextromethorphan for some of these other neuronal disorders where it's being investigated, generally you will find yourself needing to use an inhibitor to increase the serum concentration. Dextromethorphan in these neuronal disorders is being utilized mainly for its impact on the NMDA receptor. In this particular study of dextromethorphan plus quinidine, it was actually one study that included three components, which they called studies, study 1, 2, and 3. And in study 1 and study 2, they gave CYP2D6 normal metabolizers, quinidine, at various doses, along with dextromethorphan. And in study 1, they measured the urinary ratio of dextromethorphan and dextrorphan, one of the metabolites. And in study 2, they looked at the AUC for the dextromethorphan itself. What this study showed is that really you achieve maximal inhibition with quinidine doses around 25 to 30 milligrams. And typically that occurred around day 3 of dosing. They also had an arm in study 3 where they included some poor metabolizers that also received the quinidine and the dextromethorphan. And in this particular arm, they were really looking for safety evaluation, so conducted some EEGs to make sure that the quinidine was tolerable, at least in the patient populations that were poor metabolizers. So you might ask, well, why quinidine to begin with? Quinidine is not metabolized by 2D6 and has long been established as a potent competitor of this enzyme. So it's one of the very first substances that was utilized in studies of phenoconversion. So it has data with codeine, uh, with dextromethorphan and other medications that are metabolized. So you can find various phenoconversion studies utilizing quinidine. This inhibition is substrate specific with quinidine. So for some medications, it is a more potent inhibitor than with other medications where you might see the drug-drug interaction. And then I'll just point out that the quinidine dose, again, needed for inhibition is quite low. So you're talking like 10 milligrams every 12 hours versus the 324 milligrams that you might see when you're utilizing quinidine as an antiarrhythmic. Okay, now I'm going to jump to 3A4 and 3A5. This is another enzyme where you have multiple sites for drug molecules that can be metabolized by this particular enzyme. And again, the substrates are generally based on hydrophobicity with this, some of the steric site interactions. So CYP3A4 and its substrates there are many, many drug-drug interactions that you'll find basically due to induction or inhibition. And the most clinically relevant inhibitors I've listed here, mostly the azole antifungals, lots of antimicrobials, and antihypertensives like verapamil and diltiazem. 3A5 metabolizes tacrolimus, which is a medication utilized for immune suppression in organ transplants. We know that 3A5 is also polymorphically expressed, and that if you are a star 1 carrier in this case, which is a more rare genotype, then you will have increased metabolism of tacrolimus and harder to maintain serum concentrations. So there are some interest in maybe utilizing inhibitors of 3A5 to improve or decrease dosage of tacrolimus, which is a fairly expensive substance, and also be able to achieve inhibition or serum concentrations required in this population. Tacrolimus is two of the most common side effects are hypertension and nephrotoxicity, which makes diltiazem potentially a very interesting drug for a drug-drug interaction combination since it's approved to treat hypertension, and it's known to be a competitive inhibitor. The first study that we've included here is in kidney transplant population, but I liked this study because they included 3A5 expressors and non-expressors in the study, looking at changes in AUC when you provide this inhibitor for the enzyme. So here you can see the AUC when you have a 3A5 expressor not receiving diltiazem all the way up to your non-expressors here with much higher concentrations that are on diltiazem. Now, if they're a non-expressor, maybe diltiazem, what is it really doing? Well, you have to remember that also 3A4 is involved, so you're getting some additional inhibition and change of metabolism there.
And this was another study that looked at tacrolimus and diltiazem, but rather in heart transplant patients. And so they had a sample size of 17 patients, and they looked at the mean requirement per dose of tacrolimus to achieve their goal serum levels. And all of these patients were stable at the time of discharge, but then later developed post-transplant hypertension. So you got a nice snapshot of what their tacro dose needs were prior to diltiazem and after diltiazem. And you can see there was a pretty significant drop in the mean per dose requirement, and it was statistically significant. They did not in this study find any correlation with age, sex, or the dose of diltiazem. They did find a slight decrease in the required dose of tacro on the higher dose of diltiazem, but it was not clinically significant. And none of the patients in the study developed any signs of tacrolimus toxicity. And this last slide here just really highlights that nice drop from pre-diltiazem down to month 0, the time they started it, and the tacrolimus requirement.